I'm pleased to be here with the three principal investigators of the BEST-CLI trial, a critical trial in the care of patients with peripheral artery disease. I'm Naomi Hamburg. I'm professor of medicine and a cardiologist and vascular medicine specialist at Boston University. So I'm going to start with asking, what were the reasons that you did this study, and what was the question that you were asking?
Good morning. I'm Alik Farber. I'm the professor of surgery and radiology and a vascular surgeon at Boston Medical Center. So we were interested in finding out what strategy for critical limb-threatening ischemia in terms of revascularization works best. Right now, there's a lot of variation in whether open surgery or endovascular therapy is used for patients with chronic limb-threatening ischemia. So we wanted to know what therapy was best. And we designed a trial where patients who were candidates for both endovascular and surgery were randomized either to surgical bypass or endovascular therapy.
And what were the key findings of your primary outcome for the study?
The primary outcome of the study was major adverse limb event or death, and the major adverse limb event included above ankle amputation and major reinterventions. Major interventions included surgical bypass, thrombectomy, or thrombolysis. We found that both revascularization strategies are safe and effective. In patients who have good single-segment saphenous vein, bypass is better than endovascular therapy. It is more effective. It has less amputations and less major reinterventions. There was no significant difference in terms of peri-procedural death or major cardiovascular events between bypass and endovascular therapy, suggesting that both are safe. And furthermore, over the course of the trial, there were no significant differences in major adverse cardiovascular events.
And I know you did a lot of looking also at patients' quality of life. We know that patients with advanced peripheral artery disease have impairment in their ability to function in their life. So tell us about what you found in terms of the quality of life using these different revascularization strategies.
Sure thing, Naomi. So I'm Matthew Menard. I'm a vascular surgeon at the Brigham and Women's Hospital in Boston. So we did two additional kind of important sub-studies over and above the main clinical question. One is cost effectiveness. We're in the process of kind of analyzing that currently, so that'll be a third key component. What we focused on and presented this morning was the quality of life sub-study, and what that attempted to do is to capture the patient experience. So it's a component of, or it's an endpoint that only recently has gained kind of more exposure and been invoked. Very important in terms of one of the most fruitful outcomes of what we're trying to do. So what the analysis indicated was that both treatment strategies that Alik mentioned, open and endovascular, both had a very significant, or led to a very significant increase in quality of life through both arms. There was no difference when we analyzed the quality of life data, one versus the other. Heartening to realize that both, or to confirm that both revascular efforts were very effective at improving the quality of life in patients.
So important for patients. And so when we think about how we're going to use this when we make decisions for how we're going to revascularize patients who come to us with chronic limb-threatening ischemia, how are you going to put this in context when you think about what you're going to do for patients?
Well, thanks, Naomi. My name is Ken Rosenfield. I'm an interventional cardiologist and vascular medicine specialist and section head at Mass General Hospital. So one thing that's really important to underscore is the absence of data and evidence of a high level like this in the peripheral arterial space, and particularly with critical limb ischemia, and these patients have a really very important need that is unfulfilled. So this is the beginning of a journey of developing better evidence in the peripheral arterial arena, so to speak. We really have a lot of catch-up to do compared to the coronary world and the stroke world. With respect to BEST-CLI, I think it's important. It is really informs us better about how to approach our patients with critical limb ischemia, and particularly those with with this endo first movement that has been sort of dominated the sphere as technologic developments have occurred in the past 10 years or so. It's exciting, but at the same time, I think surgery still has a very important role to play, in particular for those patients who are more challenging on the endo side of things. So I think we are going to unpack this trial a little bit more and try to figure out which patients are indeed clearly better for surgery. And but I think it's important also, and Alik will say this, is to for those patients who really there's equipoise between which treatment is best. It's probably important to scan the vein and see if they have a good saphenous vein available.
So, Dr. Farber, when you think about, I know you spend a lot of time traveling the country talking to people who are taking care of patients with critical limb ischemia, with chronic limb-threatening ischemia. How are we going to overall reduce the poor outcomes and amputation rates in patients with advanced PAD?
Well, Naomi, I think it's very important to focus on that because the amputation rates in diabetics as of recently have, as you know, have increased. So we have a lot of work to do, and I think it's wonderful that BEST-CLI shines a light at chronic limb-threatening ischemia and peripheral arterial disease in general. And more studies like BEST-CLI need to be done. I think it is important for us to have introduced level 1 evidence to folks, and we need to, as Kenny said, unpack the trial more, learn more about who precisely was in the trial with respect to their anatomy. And I think we need to present this data to our colleagues so they can use these data to make the right decisions for our patients.
Anyway, I'd just add to that, Kenny alluded to it, this is the first step. I think it's enormously important to recognize that we're here at the American Heart Association meeting. We have 2 surgeons and cardiologists working together. AHA has really adopted PAD as an important cause, and there's just so much potential for awareness raising, for amputation prevention, for medical therapy to improve, and to really integrate all the different fields that hasn't really happened kind of before this moment. So enormous potential, and certainly a lot of work to do exactly what you said, translate it into kind of legs saved and better quality for the CLI patient.
Mm-hmm. And we will finish with asking about how are we going to improve the medical therapy of the patients that go along with revascularization to try to prevent adverse events? Well,
that's a really important question, Naomi. As we all know, the push on the AHA's part and ACC and others in the coronary arena or cardiac arena has really, with improved medical therapy, reducing cholesterol and so on, with statins and other therapies, has really dramatically reduced mortality. And we learned in this trial that patients with PAD are really undertreated in that regard. And I think that, and throughout the course of the trial, one of the big pushes that we made was to get patients on the right medical therapy, and we were pretty successful in that regard. So I think we're again just beginning this journey. We need to continue on it and try to improve outcomes in our patients by whatever means we can.
Well, I want to thank you all, and to all of the patients who participated in this critically important trial that's really going to move the field forward and highlight this underserved group of patients and undertreated disease. Thank you very much.